hope you all had a fantastic lunch. Now we have an exciting lineup to keep the momentum going. We're diving straight into our next session. To proceed further, I would like to invite our respected chairpersons, Dr. Terence Jose, Dr. Samuel, and Dr. Anil Bhatia. Please proceed to the dais.
Good afternoon. Thank you for coming. This topics for this, good afternoon, yeah, and people are coming. This session is on peripheral nerve injuries, and we'll cover topics including distal nerve transfers as well as tendon transfers. We have very eminent faculty here. So we'll start with the first talk by Dr. Piyush Joshi. Indications and outcomes of PQ to ECRB nerve transfer. Dr. Piyush Joshi.
This is a distal nerve transfer, but it is usually done in the proximal nerve injuries. So this is pronator quadratus branch of AIN is transferred to ECRB to produce a wrist dorsiflexion. And this was published by Betheli in 2012 in PRS. And I was lucky to see the first case at my hospital when Dr. Bhatia operated the case in 2013. There are different variations of techniques. Even Betheli has also modified his surgical technique from the first publication. And this is the way I do it. I go marking between the FCR and brachioradialis, then identify the edge of the brachioradialis. When you retract it, you can see the superficial radial branch of the radial nerve. When you trace it proximally and reach to the radial nerve, you can see the three branches there. One is the superficial radial nerve, another major branch is a posterior anterologous nerve, and in between two you will find a tiny branch which is nerve to ECRB. And for the PQ branch of AIN, we dissect between the FCR and the radial artery. And as a onco reconstruct surgeon for radial forearm flap, I just have to go in this place very frequently. So once you cut the deep fascia between the FCR and the radial artery, you can see the superficialis, and you detach superficialis part of it from the radius bone, and you can see the FDP of index finger and the FPL. And in between two, you can identify the AIN between entering the pronator quadratus. And you have the nerve lies beneath the pronator quadratus. So if you detach with bipolar pronator quadratus, you can gain a length of the AIN for direct repair. So it is tunneled behind the superficialis, and the ECRB branch is also reflected back, and you can do a direct repair. The indications for these nerve transfers are a radial nerve injury, but in a mid-shaft fracture humerus, the radial injury, the nerve grafting gives a reasonably good results. So here it is not indicated. But when it is a proximal injury, or even triceps is also paralyzed, so in this high radial nerve injury it is indicated. Second is a posterior cord injury, and the most common indication in our practice is the extended brachial plexus palsy, where C7 and C8 roots are also injured. The independent wrist dorsiflexion goes. And this is the report, the first report also came in for this indication only. So this is a radial, there is a 38-year-old male. He has a gunshot wound injury over the deltopectoral region in Africa. He was operated in emergency for vascular repair, and he presented at 3 months, and he has got a triceps is paralyzed and absent wrist and finger dorsiflexion. So I changed my approach, and I took the axillary approach as the deltopectoral region was already opened. And once I dissected the median nerve and the ulnar nerve, I am retracting, and I can find the radial nerve there behind. And from this normal area, I tried to go to the injury zone, and I found the radial nerve completely serrated there. So we identified the triceps branches of radial nerve and did a thoracodorsal to triceps nerve transfer. This was again described by Betheli in 2015 in Microsurgery Journal. And PQ to ECRB transfer was done. And this is the result at 9 months. This is thoracodorsal triceps has given this. And I offered him finger extension and thumb extension, 2 tendon transfers, FCU to EDC and PL to EPL. And this is the result at 9 months. This is the case of 23-year-old retroclavicular injury. He has got a good biceps, but no lat dorsi, no deltoid, and no triceps, and absent dorsiflexion of the wrist and fingers. This was the deltopectoral exploration. We found the posterior cord injured with axillary and radial nerve visible at the forceps. And in supraclavicular dissection, we see the even suprascapular nerve was also injured, and posterior division of upper trunk was resected. The suprascapular nerve was grafted, and posterior division of upper trunk grafted to the axillary and radial nerve. And PQ to ECRB transfer was done. And this is at 4 years. He has got a good triceps, deltoid, and good wrist dorsiflexion. But the finger and thumb extension is not there because the radial nerve grafting has not given that, and we have not yet done the tendon transfer. Rather, patient has not come for that. And this is again, Betheli has published his results of radial nerve grafting in 2016. And in this, he has specifically said when proximal radial nerve injuries are there, the distal recovery of wrist and finger dorsiflexion doesn't come. That is not very ideal. So nerve transfer or tendon transfers are required. This is an extended brachial plexus palsy case. He's a 20 years male, absent shoulder abduction and elbow flexion. The hand function is good. Wrist dorsiflexion is absent. So there is some thumb EPL is working, but EDC is again weak. And he was offered, we found a route, so we did a nerve grafting from the C5 route to the posterior division of upper and middle trunk, and then spinal axis suprascapular nerve transfer was done, ulnar to biceps, median to brachialis were done, and along with that PQ to ECRB was also done. And this is the result he got. At 14 months, he has got a good wrist extension, but the finger extension is not improved. And he has recovered reasonably good shoulder and elbow function. So the advantage of doing PQ to ECRB transfer in these partial palsies is that when shoulder and elbow recovers, the wrist extension will also recover at the same time. So the rehabilitation period is lessened. Otherwise, we might have to do a secondary procedure to do the wrist, get the wrist extension. And of course, the option for wrist extension in these cases are FDS middle finger to ECRB, which is always preserved. So even if your nerve transfer fails, there is a option to do get the wrist extension. So, and initial cases like Dr. Bhatia had published. So there is a second publication after Betheli was from India, and we have got almost M3 and M4 results in almost all cases. This publication was in IJPS. And in my personal series, there are about 28 cases, and follow-up is about 21 cases. I have got a grade 4 and grade 3 result in 19 cases, but in 2 cases, I did not get a good result. And there is one problem with this transfer, and that when you are doing it for the extended brachial plexus palsy, that some patients might lose the pronation. There is a pronation loss. Sometimes if the shoulder muscles and pectoralis major are good, they can compensate for this pronation. But if the shoulder is also very weak, they cannot compensate for the pronation, and the hand remains supine. And I had a privilege to meet Betheli in 2017 at ISSH meet. Thank you.
Any questions, please? Hi, Praveen.
Sir, very correctly you mentioned that some patients may rarely have loss of pronation. If there is some loss of pronation, has anybody asked for any treatment for that and you have done anything to correct that for any patient?
No, I have not done any treatment for that. Bethel has proposed to do FDS index finger transfer to this pronator quadratus. So to take the AIN to pick ECRB and the remaining stump of AIN, it attaches with the FDS index finger. That is what he has proposed in his publication.
Okay, sir. Because one of our patient, actually only one who has lost this and he is repeatedly asking whether anything is possible.
That is because if shoulder is strong enough, okay, fine. Yes, yes.
I would do an osteotomy of the radius and ulna.
Pronation osteotomy, sir.
Because no muscle transfer, this brachioradialis is not working. We can't do any tendon transfer for pronation. In these cases, the pronator TVX is already paralyzed, and here we are paralyzing the pronator quadratus. The flexor pronator group is also weak because the FCR isn't working. So all in all, the patient loses pronation. If he doesn't have a good pec major, as you rightly said, the patient cannot compensate it by lifting and placing the hand flat on the table. So he's
Yes,
really disabled.
Yes, sir.
Two of my cases did something like, I would say 2014, 15, I had patients who had lost pronation and were disturbed by it. Subsequently, I have not had any problems. So maybe it is the strength of the FDS which serves to pronate the forearm enough. But if the patient isn't satisfied, I would strongly recommend going ahead and doing a osteotomy of the radius and ulna.
Okay, thank you, sir.
One question, Dr. Piyush. Here.
Yeah, okay.
You said some of the indications also are extended brachial plexus palsy. In C8 involvement kind of things, how do you make sure PQ is working before you actually take the nerve for transfer?
Yeah. See, if hand pronation is good, FPL is working, and index finger FDP is working, and they have got a reasonably good power, then PQ is working. Because these are the end branch of the anterior entrances now.
So you'll also stimulate the nerve before you take
Yeah, before I take that, I stimulate the nerve. I stimulate both the nerve. I stimulate even ECRB branch, confirm that there is no contraction of ECRB. I stimulate, confirm, and then we do the transfer.
Thank you.
Thank you.
Thank you, Dr. Piyush Joshi. May I call the next speaker, Professor Dr. Samuel C. Rajpallapatti, to speak on the combined proximal, median, and ulnar nerve palsy delayed presentation.
Greetings from Christian Medical College, Vellore. The problems when you have combined proximal nerve palsies will be like paralysis of extrinsic muscles. Extrinsic muscles are forearm muscles that go to the fingers. Intrinsic muscles, both the ulnar and median. Sensory deficits and cosmetic appearance. So the problems is higher the lesion, possibility of recovery is less. Also may be associated with vascular and bony injuries. And there is paucity of transferable motor units. So scenarios where there can be combined nerve palsy are trauma, Hansen's disease, iatrogenic, and can be plexopathies, radiation neuropathy, and so many. So the aim of reconstruction of nerve injuries when it's proximal is augment capacity for activities of daily living, safe vocation, restore form and structure, social acceptance, and body image. So aim of reconstruction also is prevent further neuropathic damage. So there are many combinations of proximal nerve palsies, but I'll only handle median and ulnar nerve. So management options are definitely primary nerve repair if the patient comes early, nerve grafting if it's slightly early, and nerve transfers as Dr. Piyush has presented. So the well-executed nerve repair surpasses all attempts at motor and sensory reconstruction. This girl presented with median ulnar nerve laceration at the wrist at 3 months after injury and nerve grafting, and you can see that within 9 months she's got both ulnar as well as median intrinsic recovery. At 9 months follow-up, she can hold the lumbrical position, showing that intrinsics have repaired. This girl came from Nepal. Both ulnar and median nerve at proximally near the elbow. We did surgery for her and median nerve grafting as well, ulnar nerve grafting. She came back after 7 years. You can see that she's able to oppose the thumb to all the fingers, and full closure. That means both extrinsic as well as intrinsic muscles have recovered. But the problem is when the patient presents beyond critical limit of delay. Critical limit of delay means time period beyond which even if you repair the nerve or graft the nerve or transfer, the possibility for motor recovery is not there. That means motor end plate degeneration has happened. So there are many possibilities that you can do: tendon transfers, selective joint fusions, static procedures like capsular desis, nerve transfer, neurovascular island transfers. Sometimes nerve grafting can still be done in the hope of getting back some sensation, and good health education is required. So you all know the tenets of tendon transfer: no contracture, adequate strength, good amplitude of motion, straight line of pull, one tendon, one function, synergism, wrist expendable donor, and tissue equilibrium. So good preoperative therapy is very important before you can do a tendon transfer, because a transfer cannot work against a stiff joint. So when you have proximal nerve injuries, the reconstruction goes like: extrinsics must be reconstructed before the intrinsics can be reconstructed, and proximal to distal progression of restoration of motor power is preferred. So what is the deficient usually in proximal injuries? Finger flexion, finger extension, wrist flexion, and if the radial nerve also involves wrist extension. And primary intrinsic deficits are they have a claw hand, adducted and supinated thumb. Okay, so they again the same thing: paralysis of all long flexors, intrinsic paralysis, total claw hand, but there is availability of radial nerve supplied muscles for your reconstruction. So the standard set of transfers that we do usually is for thumb flexion BR to FPL, for finger flexion ECRL to FDP transfer, and thereafter we do a static claw hand procedure and EI opponent's plasty. I'll show you some examples. This is, I pulled this out from the archives. Preoperative documentation of motor sensitivity is very, very important. As you can see here, for this patient who had this cut injury at the elbow, both median nerve, ulnar nerve not working, all median nerve supply, ulnar nerve grade 0, as you can see in the documentation. And he's got a, sort of a claw hand. So the surgery that was done was ECRL to FDP transfer, BR to FPL, and EI opponent's plasty. So you can see full closure of the fingers and thumb is in good opposition. This is another example of a gunshot injury, as you can see near the axilla. Both median and ulnar nerve were paralyzed, grade 0 power. He had the transfers ECRL to FDP, BR to FPL, EI opponent's plasty. Again, you can see full closure of the fingers, the thumb, and also good opposition of the thumb to the fingers. This patient with Volkmann's ischemic contracture, same transfer, but the FDP tendons were all scarred, so we had to do the transfer of the ECRL through FDS graft to FDP. He's got good closure. So the problem when you do the extrinsic correction is, after the correction is over, you start noting the claw hand deformity. So this patient has full closure following the transfers, fingers are fully closing. When she extends, you can see the claw. Thumb is adducted and supinated, and the total claw. So when you reconstruct the extrinsic muscles, the claw appears. And so what's preferred for in this kind of patients is a static claw hand procedure. For example, tenodesis or capsular desis. This is an example of volar capsular desis described by Zancoli. And this is a patient, preoperative. He's got full closure, he's got a claw hand. We went on to do Zancoli's volar capsular desis. The claw has disappeared. Also EI opponent's plasty. Just a word about distal ulnar median nerve. They have total claw hand, no opposition. This is a good example where you can do FDS transfer. The splint I'm showing is the Karigiri splint where Dr. Fritchie and all worked. They developed this splint where you can position the hand over the splint for doing a four-tail split FDS transfer to all the fingers through the extensor apparatus. So there's a claw hand. So when you have both median and ulnar nerve involvement, you can do total claw hand correction, including opponent's plasty, like in this patient. Yeah, preoperatively you have total claw and claw corrected and opponent's plasty done. So yeah, sometimes when you have the median nerve involved and you have ulnar nerves paired, for sensation you can do Littler's neurovascular island flap, like so here. The flap taken from the ring finger, transfer to the thumb, and so they have sensation in the thumb. At the end of all your reconstruction for the extrinsic and intrinsic muscles, patient still complains about the void in the first web. So you can do that. You can correct the void by doing a dermofacial flap use for the thumb web. And also we have been doing lipofill for augmenting the interosseous spaces. So to conclude, combined nerve palsies affect the hands greatly. Difficult problems to treat. Various management options are available. Surgeons should use these options judicially for best functional outcome. Thank you.
Thank you, Dr. Samuel, for the outstanding presentation. Any questions?
When you do this capsulodesis, do you see over a period of time they get stretched out?
A bit so you put it slightly tightly, and we have been putting some couple of patients into the bone so it won't stretch. Not only double breasting the volar plate on itself, but we have done put the capsule volar plate into the bone of the head, neck of the metacarpal so it doesn't stretch. The
So, but
patient I showed,
it doesn't get stretched out.
not much.
So it does.
If it goes into bone, no. If it is into the volar plate, it can stretch. Yes.
Thank you.
In club case palsy, have used the paralyzed FDS as a potent lasso,
As a static, is it?
as a static lasso.
Yeah.
And since the extrinsic extensors that come from reinnervation of the extrinsic extensors from the
Yeah.
nerve transfer,
They don't show claw.
does tend to get corrected.
Yeah.
I don't know whether that would be relevant in combined palsy.
Yeah. Still, yes. It says when you don't have the motors available, you can still do static procedures. FDS, is one of the things that's described. Yeah.
Thank you. May I call the next speaker, Dr. Srikanth, to talk about the rewiring muscles, training techniques and strategies.
So the muscles are rewired to get the desired function at shoulder, elbow, wrist and hand depending on what their primary pathology is. So post-operatively we have divided our rehabilitation program into 5 different phases. Phase 1, patient should have tension-free positioning of the extremity, and then we maintain the passive mobility of the joint. And then in phase 2, as the muscle starts to reinnervate, training of these muscles become challenging because patients objectively do not have any visual muscle contraction. So in such situations, we use EMG biofeedback. And then bringing in that patient from grade level 1 to grade 2, it's a bit of a challenge. And then as the muscle starts to progress from grade 2 to grade 3, it's even more greater challenge because the extremity should move against gravity effectively so that the person has mobility, in flexion extension. Extension is always towards gravity, whereas flexion is towards against gravity. Now when we want to bring in the muscle contraction from grade 3 to grade 4, then we consider using EMG triggered electrical stimulation. And we use dynamic assist blunting, and I'll show you some example of those. And then we go on to progressive strengthening. So these are the phases of our rehabilitation program. So phase 1, as I mentioned, that we position the extremity to protect the transverse. However, we maintain the extremity's mobility depending on the limitation that surgeons have mentioned in our referral system. But as the muscle starts to reinnervate, we know that ultimately the muscle starts to show some contraction, but it's flicker in nature. So initially, the motor function is undetectable. Muscle improvements, of course, gradually happens, and we grade them from grade 0 where nothing is happening, then to grade 1, then to grade 2, 3, 4, and so on. So if you look at the muscle improvement, we know that it's based on the MRC scale. Grade 1 is when there's a flicker, and to bring in, strengthen these muscles from grade 1 and to bring it to grade 2 is definitely a lot more challenging, not only for the therapist, but also for the patient. And then bringing in the grade 2 to grade 3 produces or requires a lot more muscular strength and muscular contraction so that the extremity can move against gravity. So you can see these challenges presented by the MRC scale that we use in order to retrain these muscles. But that's not all. The muscles ultimately require that it should be conditioned in a way that we have a strength, but on top of that, the muscles also have an endurance to keep on producing sustained contraction for the activities that they perform on a daily basis, sustained contraction of the muscles for their functional activities throughout the day and so on. So these are the challenges. So how do we overcome this in therapy? So when the muscle starts to show some nascent units, we use this particular device. It's called as the Myo Plus 2. It's available on the rental basis. Patients, if they prefer to carry that or pay for the rental, that's fine, but otherwise we have few units in our department. We educate these patients and their families thoroughly about the usage of this device. So as the nascent units form, we train them extensively to show how this particular device can be used. And with repeated muscular contraction, patients learn to produce muscular contraction and the muscle gradually starts to improve. And then if you look at the method of our rehabilitation for these patients, we know that this unit detects the activity from the muscles. It displays in a form of a graph. It displays in a form of an auditory signal. So how do we set up these parameters? We initially set up high sensitivity and lower threshold. The threshold is set such that patients have a capability of reaching that threshold consistently for a certain length of time. So this unit is programmable, and this prompts the patient to produce a muscle contraction. So the prompt the patient gets, contract or work, and he'll keep on working and try to sustain muscle contraction for maybe 3 seconds or 5 seconds depending on at what stage they are at. And then as the muscle starts to get better, we lower the sensitivity so that the patient has to produce even greater muscular contraction, and we gradually increase the threshold over time. And once the patient reaches between 70 to 80% of sustained muscle contraction, at that stage we program the unit to produce muscle contraction. So that means that when the patient reaches a certain threshold, this device starts to electrically stimulating these muscles. So here, of course, let's see whether this video works. So this is the patient who is working in a gravity eliminated position. We have designed a system such that the arm is suspended so that they are not lying in supine. And that becomes a lot more challenging, especially if they are supine, they may have some added resistance produced by the surface they are laying on. So we have an arm system where they suspend their arm in a gravity eliminated position. They perform flexion and extension of their elbow joint. So here, of course, the muscle becomes stronger. As you can see that the moment they reach certain threshold, the electrical stimulation kicks in and the muscle starts to become stronger. And we keep on changing these parameters until such time that the patients have better and better strength and sustained contraction for certain length of time. So normally patients have difficulty moving their elbow. In such situations, we make a dynamic assist splinting, and this dynamic assist splinting starts to further train muscle contraction so that the patients are capable of using their hand for functional activities. And as the muscle strength improves, then we discontinue the use of the device. So here this patient was diagnosed with cervical spondylotic amyotrophy affecting C5 and C6. He had a nerve transfers for elbow flexion and shoulder motion as well. 2 months post-operatively, he started showing flicker and that's when we used EMG biofeedback, and from there on we continuously use the same method of management as I described earlier. And then from here on, with use of dynamic splinting, we continued getting greater and greater strength, and finally he came to a stage where he did not need any more rubber bands. So here, of course, is great 4 and 5 phase of our mobilization, and finally the patient has great range of motion of his shoulder, of his elbow, and here, of course, he went back to work despite of our recommendation that he's not ready yet. However, we suggested that he uses his brace if he notices his muscles are getting fatigued, because the muscles did not have adequate amount of tolerance. And 1 year, 8 months post-operatively, he back playing golf. He still continued using his elbow brace from the muscle fatigue point of view, and it almost took him 2 years for him to not use the elbow brace, and he continued functioning well, and recreationally he continued doing various sports activities. So this is an ulnar nerve palsy. We know the test that we commonly do. So this is an AIN transfer to the deep branch of ulnar nerve. We use the EMG devices, EMG biofeedback devices. Here we are using EMG triggered electrical stimulation. Unfortunately, you can't hear the sound. And here the function of the hand. As you can see, great motion post-operatively. And of course, in conclusion, we train the rewired muscles in a specific manner, maximize their ability so that they have greater function eventually. So the highlight of my presentation is basically use of EMG biofeedback and using EMG triggered electrical stimulation along with dynamic assist splinting, and it gives us great results. Thank you.
Thank you, Dr. Srikanth, for the outstanding presentations. We'll avoid questions right now. We'll have at the end of the session. We'll stick to order from the organizing team to pick on the time. So
maybe at the end?
At the end, we'll have some questions.
Okay,
I'll call the next speaker, Dr. Ashwat, to talk on the current concepts in peripheral nerve injury management.
Good afternoon. So let's get into some of what recent updates what we've come across in the last few years. Now we are standing on the works of the legends of nerve surgery. So it's all started with the pioneer Ramon Cajal, who got the Nobel Prize, and what he has drawn, the drawings which he has drawn about peripheral nerve healing. Now it was almost 100 years back, and the same diagram still holds today. The concept of staggered regeneration, which is being talked about so much of late, was exactly the same which he drew, although that knowledge was not there at that time. Now, standing on other legends who subsequently followed, Seddon, Sunderland, Lundborg in the 70s, then Milesi, Narakas, Oberlin, and more recently Susan McKinnon, Brunelli, and of course Bertelli. Now, what do we know as of late? So what we now know is there's something called a staggered regeneration. This is one of the reasons why the delay in peripheral nerve happens after neurotmesis. So basically it's a process of asynchronous slow axonal growth across the site of injury. So it's a stepwise very slow process of regeneration where the axons move out and also back and forth, and subsequently a preferential motor regeneration starts after some time, maybe a month later. That is been shown in rat models, where following repair initially both the sensory and motor axons enter the target, but after some time a very selective process of motor axon entering only the motor side distally, that happens after some time. So this was one of the recent concept which was told. And why poor results happen? The earlier concept which we still follow, which we still is there in our awareness, is the concept of myoneural junction, the degeneration or denervation of the muscle. But what Now, based on experiment, new research which says that it's a significant contribution is coming from the loss of neuronal cell at the spinal cord. So chronic axotomy causes 66% loss. Hardly around 30% of the axon ultimately reach the muscle, but that is well compensated. But what is worse is the distal segment where you have a significant loss of the Schwann cell. So Schwann cell denervation is one of the maximum contributor to the loss of, for poor function. And of course, added on that, the denervation of the muscle also has a contribution. So you have all the three together. So ultimately, the axons which reaches due to delay is hardly around 10%. So there's a lot of research going on to improve that function. So now moving on to our the diagnostic aspect. Now we still rely on electrodiagnosis, and not much has changed. But what we have seen is in the MRI, where new research has come up and new kind of images, which is one of them is the diffusion weighted imaging and the diffusion tensor imaging, where you can actually see the axonal type, the diameter, myelination, density, organization on a microscopic level. So that kind of imaging system has now slowly come up, and you can beautifully demonstrate the avulsion and so on. And even the regeneration part the growth of the axon has been shown in the MRI images, but these are higher generation one, so more will come up in the coming few years. Even the ultrasound has shown remarkable progress because of the new kind of high frequency probes, the portability, and of course the advent of AI has added a new dimension. So we have muscle denervation, the local compression, all can be beautifully shown. Now moving on to the repair aspect. Now one thing which I have come across and which I wanted to tell was the concept of fat grafting. So autologous fat grafting has been in vogue, but for nerve injuries it has come up in recent times. And usually what I generally now do after reading this is to preserve a vascularized pad of fat and cover it with the graft. So in brachial plexus I routinely do, and we always do that for intercostal nerve transfers. Now moving on to the concept of gap. So autograft remains a gold standard, and one thing which I wanted to stress was that this graft gets adhered to the bed. Okay, so because of the centripetal revascularization, the graft will not glide. So to prevent a rupture of the graft, it's important that we maintain zero tension, and the graft length has to be a little longer, and it has to be in a maximum stretched position. Okay, and always very important to identify the proximal end. Okay, that's where some of the mistakes happen, particularly in brachial plexus injuries. So more about that, when there is a long gap, now we know that there is the problem with the denervation of the distal segments. The new concept of the babysitter procedure has come up, the supercharged nerve transfer. Now that has been becoming very popular. The cross bridge nerve grafting, and of course electrical stimulation. Conduits, a lot of things are in vogue, but usually they are still being used only for sensory nerve reconstruction. What we have been doing is use a vein and muscle in vein graft, which Brunelli had popularized, and that has given fairly good results, and recent reports have shown a very good sensory recovery also. Now moving on to distal nerve transfers. So now we have new nomenclatures where, now it is very refined system of, naming these transfers. So you have end to end, end to side, end to side to end. These concept and side to side have become very clear. So one good example which have become very popular is the distal nerve transfers for high injuries. For example, this is one median nerve injury where the ulnar nerve distal branch is transferred to the thumb. So within 5 months we can get a fairly good results for a very high proximal injury. Patient have very good abduction of the APB restoration. Now, the same thing can be applied for end-to-side anastomosis also. So here is one example of the AIN transfers. So this has become much more commoner. So sensory nerve transfer we are now doing more frequently for pain relief in brachial plexus. The distal nerve transfers are becoming more and more common. So this was popularized by Susan McKinnon. And now we have newer methods of, if I can get one more minute. So electrical stimulation, and the other concept is the polyethylene glycol, and also certain drugs like tacrolimus, which our hand transplant colleagues have been talking about. Now this is something which is a lot has been talked about. Now basically this is per operative electrical stimulation of the proximal end of the repair. So basically it's set to act because of its action on the cell body in the spinal cord, and it enhances the axonal outgrowth and also enhances the rate of end organ reinnervation. And it also encourages motor and sensory specificity. Okay, the preferential regeneration is also enhanced, and it improves the functional outcome. And what they advocate is 1 hour, but now it has been reduced to 10 minutes. The other popular one is the tacrolimus. Susan McKinnon talks a lot about this. So, and also Tessa Gordon. So, where now they are applying local tacrolimus using conduits or hydrogels, which is known to hasten the recovery of the nerve recovery. And the other thing is very interesting one on which we also had worked in recent times is the polyethylene glycol fusion, where the drug actually induces cell fusion, or the axons get fused. Now this works only in a situation where Wallerian degeneration has not set in. Okay, so what happens is the electrical conduction is immediately restored after you apply polyethylene glycol, after your repair. So the axons reconnect and electrical conduction starts. So that has produced dramatically improved results. So when you add electrical stimulation to that, the outcomes are usually better. But of course, there is a window period that it has to be done before the Wallerian degeneration sets. And there are, of course, there are numerous other drugs also. A lot of experiments are going on in this field. So more about this sometime later on. So to summarize, you have the distal segment of the nerve injury, which is the biggest hurdle. A lot of work is going on to improve the results or improve the Schwann shell survivability. So you have nerve autograft, which still remains the gold standard, and distal transfers are more and more frequently done now. And newer biological methods have evolved, but more testing needs to be done for them. Thank you.
Thank you, Dr. Ashwath, for that. I think we're running short of time. Shall we wait for the questions to the end, till the end? Yeah. We have Dr. Terence Jones, Jose Jerome now, speaking about innovative distal nerve transfers, techniques for peripheral nerve injuries. Dr. Terence.
Thank you, sir. Good afternoon, everyone. These are my disclosures, and this is my team which started my journey. So what we have understood from the brachial plexus injury is that we at least know at what time to intervene. But little is known about for the distal nerve transfers in the forearm and the hand. Look at this patient. He has a high median nerve palsy. And this is what routinely been seen in our patients. And what we advise is that we do a conventional tendon transfers. What we do is we suture this FDP with the adjacent middle finger. And at the outcome, we can see the deformity persisted. I mean to say that the patient did not get any improvement. If you do a nerve repair there, look at this patient who had the nerve repair somewhere here. This was the injury. And the outcome is that he could not get independent movement at the IP joint of the index finger. So we are just still moving apart from the nerve transfer. What we could do is we could do a distal nerve transfer. This is a case of patient who had a high median nerve palsy here. And this was the presentation. He's a medical student on the right side. He doesn't have the independent movement of the FDP on the index finger, no movement of the thumb. And and abduction was not good. There was no FPL and there was no movement at the FDP finger of the index, and this was the movement of the FDP. So what we innovated was that we found the erector branch of the terminal divisions from the ulnar nerve, and then we could do in addition ECRB to the anterior introitious nerve branch. What we could get the movement is that this is what we could get. Much need to be seen in this video is that you could do an independent abduction of the thumb. At the same time, you can do the independent flexion of the IP joint of the index finger, which can also be done only by doing the distal nerve transfers. And these are the results of this patient. In addition to that, what we routinely don't see is that we see abduction, but we forget to see the FPL. So this patient has independent movement of the FPL, meaning to say that the AIN is completely reinnervated. So these are all the, somebody says that, no, you are taking the nerve from the adductor terminal branch of the ulnar nerve. These patients do not have any deficit at the follow-up because there are two branches of adductor nerve branch in the hand. So meaning to say that every donor has two branches at least where one can be sacrificed. Then why distal nerve transfers? These are very close to the end organ, and of course can be or you can get more than one movement, because as professor says that tendon function is one tendon, one function, but one nerve can give multiple function. So this is a case of a lateral cord injury who came to me with without high median nerve palsy and also the without abduction, the elbow flexion. What we did is we did the routine Oberlin transfer for the elbow flexion. In addition to that, what we found was this was the anterior introitious branch. This is the recipient here, and we found the FCU branch of the anterior introitious nerve at the same time, and we could transfer the nerve here. And this was the follow-up movement at 12 months. Meaning to say that these movements or these distal nerve transfers do have a good outcome compared to what we do routinely tendon transfers or other transfers. And this is the functional outcome. So we have moved from, we explored all the options of distal nerve transfers in the forearm using the ECRB, using the AAN and different sorts of nerve to give. So we have modified and we have published this as a new article taking the ECRB branch to the anterior introitious nerve, and we could get this movement. Similarly, a medical student which I showed you, and this was the presentation of this patient where he had there was no elbow flexion at all, and what was there is the brachioradialis is working there, and you can see this was a brachioradialis, no elbow flexion, and this was the movement where he was having before surgery. And what we do is we could do the Oberlin transfer there. In addition to that, the forearm, we could do the approach of the transferring the ECR to the AN and then a hand function. So at the final follow-up, this was the movement he sent from the medical college there, and this was the follow-up movement. Do the all elbow flexion, the function, he joined back the medical college back. And again, a case of posterior cord injury where definitely there is absent triceps, absent wrist and the finger extension. And you can see the biceps is working there. These are the x-rays of this patient. And what we found that was the posterior cord was thick and highly avulsed from the origin. And we did the Oberlin transfer for the elbow flexion. At the same time, what we could find was the median head of triceps nerve this patient. This was not working. So we found the FC branch of the ulnar nerve at the elbow, reversed it so that it can come and meet here and it can co-opt the nerve at this level. And in addition to that, we did FDS branch to the posterior introitious nerve. And this was the nerve we could do at stimulation, and this was the follow-up. But since the there's no donor deficit in taking the FCU branch or even little distal in the palm, because there are multiple branches to compensate for that. So this was the one of the criticisms is that what is the follow-up of taking a branch from the ulnar nerve? So no deficit or no claw hand in these patients. So at 6 months follow-up, this was the functional outcome of the patient. Again, a radial nerve palsy who came to us with this deficit wrist drop, and we could do the FCR branch to the posterior introitious nerve, the FTS branch to the ECRB, and as Ashwath was mentioning about the superficial radial nerve branch to the median nerve to provide sensation. This was a new technique which could get it, and this was the follow-up of this patient at the 12 months follow-up. I could get the finger extension, get all movement at the wrist, a reasonable finger flexion and finger wrist flexion and wrist dorsiflexion. This was at the time of final follow-up. And what was interesting is that if you could see this video here, so these are all the nerve transfers of this patient where, watch this, so he could not have a dependent life. See, for everything, for putting even shirt or buttoning shirt, he has to depend on the wife. So in this scenario, this was the beautiful outcome where this distal nerve transfers in the forearm and the hand definitely can change the life. And this at the end was that he could do all this work, independent. He has started back to his wife work, and then he become an independent breadwinner of the family. He doesn't need to have a sort of dependency in his life no more. Again, another patient with combined radial nerve and median nerve palsy who came to us with this preoperative video with the wrist drop and no functions of the median nerve. So what we could do is the only donor nerve was the ulnar nerve. So we could get as much as donor nerve from the ulnar nerve. And then what we did is we found a new way of doing the FCU branch passing under the muscle of the pronated and then bringing it to the ECRB branch, a new technique which we found it, and then it was working when we found this at the final follow-up. The wrist drop improved, and slowly he also got the function of the median nerve slowly working in this patient. So these are all the technical advancement and also the appealing results of the distal nerve transfers in the forearm and also in the hand. So and other nerve transfers in the hand. This was the nerve transfer which I could quickly pass through. So as usual, what we do a zigzag incision here. What you find is the terminal branch of the adductor between the two heads of the adductor muscles. We need to stimulate those muscles there, and then we need to stimulate those. The recipient is the abductor branch. It could be opponent's branch or the abductor branch of the median nerve there, and so you can stimulate and can see the contraction of the intraosseous and the adductor here. This is more important in doing all those surgery. Before cutting, you need to stimulate and see which. This is the nerve which is the donor. You can see the contraction of the intraosseous there, and also you're going to take the adductor branch there, which is the donor. And then we just need to transfer it to the abductor branch of the opponent's pollicis, or the abductor branch, the opponent's pollicis branch of the median nerve, and we could get the final result there. This was published in the JBJs as a surgical technique, and these are the follow-up of the patient. And this is the final follow-up. 30 seconds, sir?
Yeah, I think
Sorry.
we're done because I need to go also to the next
Yeah.
session there.
Any questions? This can also be done for the ulnar nerve. Like you can transfer multiple nerve branches in the forearm and in the hand to get the reasonable outcome. See, the principle is that tendon transfer is one tendon, one function, but the one nerve can do multiple functions. For example, if you target ulnar nerve, you can do abduction, adduction, thumb adduction, wrist flexion, position, or the abduction of the little finger. We need to say that distal nerve transfer are welcoming, and it's very close to the end organ, and it is doable.
Yeah.
Thank you so much.
Terence, thank you very much. I think for lack of time, if you have questions, you can meet the speakers individually, because the next session starts at 3 o'clock, also in the next other rooms. So thank you very much to all the faculty. Thank you, sir.